So you'll have to use this. Oh, wait, hold on. There we go.
Just space.
You can use the space too. Yep.
Or back and forth.
Yep.
Thank you.
Of course. Oh, and the,
Starting at 8.
yes.
10 minutes to go.
Yes.
Right. Guys, I mean, that, no, it's in a little right now. Yeah. What? I want all that. Oh, yeah, Don't we do? She was what a president. There were. The right stuff. It's funny. Oh, yeah. Yeah. I like it. Can't tell around the shit. I'm fine. And then you're reading on a family or. Well, so thank you for my. I'm a boss. You don't say like 3 down. Share the people with on. Was after elementary, it's like part of that. I think for they live out. Not the they're updating the day. So she has that. You know, I know my mom's. Yes, it's just oh God, we don't ever yeah. Oh, it really I think like it was a teaching. Yeah, it's she wouldn't want to be a good like it was but there were teach that it so then she was trying to cover that. Suicide. I'm the daughter thing on the work. This was that she didn't know it. She did. I was there. I was just 10 years ago. That's a civic with us. Okay. So that's very well to have those. That's all right. Don't die. She said, oh, they're not putting my daughters. Hello. Yeah. You would trash me and all everybody's phone and she's all the state. So it's a certain like that. Yeah, she was there. It's one. So it was kind of just one. Yes. I was education awesome. And my rest was yeah, as a people obviously that's whatever did. That's kind of the here's what it dies. Yeah, what do you think I told us about patient there? I have a He was good with students. Early when you were first. Oh, but also. That was the. So it wasn't like some therapy that, yeah, it wasn't like it was something good with these. Just that. There's so many of them. I think it's well there. So I think. Well, that was right. That I said, okay, we're just. What page was that? In the January. Talking. Like. There, motivation of the sun that area. Or the services that I still need to make. So the people go to specialists. All right. Right. It's only monitor. It's going to be discussing right. There should be stuff that I just think. Even more than that. When I go to the slab, I think that does be a sure. I think she's still reading. So the speaker. It was kind of blocking, you know, and I don't think that was also something. So it was no reason that also some night worship. So really should put always. And the last, you know, yeah, that's why. Yes, in the mornings. And then then they do the one who came on. So I was together. Yes. After the scene of the stitches. And as we started walk, people give one of those durable fish with absence. So yeah, which is the benefit ass. I think it's going to take things. Yeah. Because what's you? And oh, awful. Great. Part of the shoes. It was like Saturday night. Sad. I get so big. We were on whole page. Saturday morning. Coordinating. Really big. We had what we had. We just had a next day. The rest is approved. Right. But most times. Well, they have something to do. They go in and figure out. Oh, they all 4 days. Just. Why I'm sweating. Very long, very cold. Yeah. And oh, that's your. So yeah. Very cheap. And somebody has something with guys here. See how they went in at the side. And they went across. But I wish I could remember that. Just as different people. I know. And then they thought they had a few times. No, that's first. Yeah. And interested because it was right. You know, the first thing was coffee. Oh no. Oh, because I found the books. Well, I was sort of while I go forward. Oh, that's about standard. So was that they find me really. Oh, I don't think that. I don't say you know, I went on Sunday, I didn't like getting there and like I couldn't be here. Oh, I did this one. As far as I mean, during the morning, well, I don't know, it's I've been at campus. I'm not probably to do it. In your grandkids speak, what you're saying. You know, I'm involved with. Yeah, yeah. Okay, so that's your other. Right, decent. Well, I think hotels that around. Very bad, it's just scary. We're in Green Bay, but I saw something called to an Atlanta. Okay, and you probably know. Maybe. Okay. Yeah, okay. Yeah, that's good. It's pretty not water. Yeah, we're in Green Bay. Yeah, okay, great. Sir, bye. They just said, I signed up. He was going over this. He said. And then I ended up being. I didn't hear him going about it. It's in exams and it in every. Years. And then they took some. And now the milk is out. Actually, we're going to again and let it go. And he goes to the car. Then he said, that we were in Congress sitting on the ball and we faced when they hear friends. He never did her son's it was an opposite. She's going all over the field. Yeah, just hey, I should be off. Customers. So that's that. They all came to play. It was getting lots of words. We love that says that couple, so now I did that, but I was just thinking. Because they, son, if they had to have the meat, so. Oh, no, a lot of bad. I said, no, 6 years. And I'm so think Sean, it's 1 of 6 years. But you know, the also son, I think about just really good to the fun. So yeah, they're trying to like to get sugar. Maybe one transfers. He and it's weird on options. Said that and
Good morning, everyone. Thank you so much for joining us this morning for our Wellness Wake Up series. We're glad to have you. This is our first segment of the 2026 year. So we do these quarterly. So please stay tuned for more series as we publish them. If you haven't already, on this side, the cardiology team has provided some little heart stress balls if you'd like. We also have flyers on both of the providers that will be speaking today and pens and some paper if you'd like to take any notes. Over here, if you haven't, we have some breakfast that's been provided by Cafe A Go-Go, which is located in this building on the first floor. There's coffee, yogurt parfaits, scones, and crumb cake. So we are going to kick it off right now with Dr. Zabar, and we'll take a little 5-minute break in between, and there's restrooms around the corner should anyone need it. Thank you so much. Doctor?
Perfect. Thank you so much. Good morning, everyone. So my name is Harun Zubair. I'm a structural intervention cardiologist over here. Better? Okay, perfect. Maybe I have to have it closer. So So my name is Dr. Haroon Zubair. Can you hear me now? Perfect, awesome. So I'm a structural interventional cardiologist over here at Aurora BayCare. So I've been in Wisconsin now for about 6.5 years. Before this, I was in the Northeast. I'm originally from Pakistan, where I did my med school. So with Aurora for about 5 years in Milwaukee, and now I moved to Green Bay in August of last year. So I'll be talking about aortic stenosis, which is basically tightening or hardening of the aortic valve. And I'd love for this session to be interactive. So at any point, any questions, you can just stop me and ask me, and then I think that would be probably the best way to go. Okay. So this is essentially a summary of what we'll be talking about. So the first question naturally is, what is the aortic valve and what is aortic valve stenosis? So the easy way to kind of remember layman's term is it's essentially the door. A little better? Okay. So the aortic valve is essentially the door which connects the heart with the rest of the body. It's the last valve which connects the left ventricle of the heart with the aorta. So what that essentially means is that with every heartbeat, the blood comes out from the heart through this door and goes to the rest of the body. So what can happen primarily most of the time with genetics and with aging is that this valve or this door becomes very tight and very hard and calcified. So when that happens, naturally the blood, which is food for the body, doesn't tend to get out of the heart, and then there's less blood coming out of the heart and going to the rest of the body. So essentially, the body is not getting its food. So that's the problem that we're going to talk about, which is called aortic valve stenosis. This is a real time autopsy picture which looks at it. So the structure in the center over here is the white structure. That's the aortic valve. You can see around normal human body looks nice and pliable, and the tissue is supposed to be very red and soft. The center structure is very hard and calcified and white. It's very hard like a rock. So that's the end result when the valve becomes really, really tight. This is, as we talked about, most of the time happens in people above 65 to 70 years of age. Doesn't happen in everyone. The most important factor is lifestyle and genetics, which can lead to it. Other uncommon conditions such as congenital, people are born with it. In those patients, the disease usually manifests a lot earlier, sometimes even their 40s and 50s. And other causes such as infection, rheumatic fever, that's now more or less in the developing world. In the developed countries, the US, we don't see that very often now. So this is a picture from the American College of Cardiology looking at the progression of the disease. The valve you can see on the left is mildly diseased, on the right is severely diseased. So the valve is supposed to open like a big, nice gate which opens. Over time, when it becomes really tight, it just opens like a slit. So what that means is when the body and the heart is not under stress, somebody just sitting in a chair, not doing anything, they're doing fine. When they walk around and they work, the valve, the door doesn't open as it's supposed to. The body doesn't get blood, and then people start to get symptoms, which is the next slide that I'm going to talk about. Classic symptoms of aortic stenosis, chest pain or chest discomfort, primarily when people move around or do something. Shortness of breath, especially noted again with activity, and lightheadedness or dizziness. These are the three classic symptoms associated with aortic stenosis. Sometimes people can also have very, very significant weakness or fatigue, most of the time seen with exertion. An example being somebody comes in and says, hey, 6 months ago, I was able to shovel snow. Or 6 months ago, I was able to go up and down 1 flight of 2 flights of stairs without any issues. I was walking for maybe a block without any concerns. Now my activity is significantly reduced. I can only do half that activity. And doctor, I'm just so tired. I don't know what to do. So, and other things would be chest pain, shortness of breath, obviously, that we talked about, and lightheadedness or dizziness or passing out. So those are classic symptoms of severe aortic stenosis. This is a busy slide. This essentially is how we diagnose the disease over here. On top, we have CT pictures. The left part, you can see all gray. And on the right side, that very, very white and bulky things, that's the valve, which is very calcified. The bottom pictures are echo pictures. It's the ultrasound of the heart through which we essentially diagnose the disease and see how much is the obstruction. Key thing that I'd like to stress at the bottom, because naturally for us as well, coming into medicine, cardiology, of course, we are trained to do procedures, but the most important thing for us, for ourselves, for our family members, for our patients is preventive medicine. The best thing would be if it doesn't reach to this point. At the bottom, we talk about risk factors, cardiometabolic risk, a genetic risk, renal dysfunction, congenital defects. Then why the disease progresses, it's essentially stress and wear and tear. So simple things being simple, as is the case with most diseases, especially with most cardiovascular diseases, the best way to prevent is healthy lifestyle, good diet, exercise, and minimizing risk with blood pressure control and cholesterol control. In a significant amount of patients, obviously, preventive medicine is the best way to go. We are here, and obviously, the topic of discussion is severe aortic stenosis, which I'm going to talk about what treatment options we have. But clearly, from any doctor's perspective, the best thing is preventive medicine if we can avoid getting to that point. So now the question becomes, so we have talked about what the disease entity is and what sort of symptoms happen. So why be aggressive about it and why fix it? So this is data from like multiple research, which is established with all like cardiologists over here. So if we don't do anything and we don't replace the valve either by TAVR procedure or by surgery, then you can look at the numbers like, and obviously we cannot guarantee what's going to happen for one patient. Doctors can only predict with what the data is. The rest is obviously up to a higher power. As much as 50%, so half of these patients can die within 2 years if we don't do anything. 80% of people don't make it beyond 5 years with what research shows. The classic treatment until about 15, 20 years ago was surgical valve replacement. Naturally, that's very invasive. We have to open up the chest. It's open heart surgery. That's still the best treatment for people who are younger than 65 years of age. Now, for the past decade or 15 years, this TAVR technology is there to treat this disease entity in people who are older than 65 years of age. Untreated aortic stenosis, again, we looked at it. So mortality of up to 80% at 5 years. These are other things that can happen: heart failure, sudden cardiac death, and worse quality of life. The classic pattern that we see is people essentially keep going in and out of heart failure once the disease becomes severe. So what it could look like is somebody comes into the hospital, gets admitted to the hospital a few times, has to be on medication such as Lasix or furosemide. You get rid of the fluid, then they go home, they feel better for a few days to a few weeks to a couple of months, then the fluid builds up again, they come back. So it's not just living longer by treating the valve, it's the other major part is the quality of life with that as well. And one question that I always get asked is there any medication to fix it? That's why I wanted to share those pictures from autopsy and from heart specimens from surgery. When the valve becomes so tight and so calcified like a rock, unfortunately, there's no therapy or there's no treatment to treat it except for replacing the valve. In the future, maybe 10, 20, 30 years, we might have gene therapy or other options, but right now we don't. The only option at that point is to replace the valve. This is the conventional open heart surgery. Still a great option for people less than 65 years of age. Very classic, conventional. At that point, I would convince my patients to say that, hey, open heart surgery is the treatment for you. TAVR treatment is usually we consider for people 65 and above, classically 75 and above. 65 to 75 is a gray area where the structural cardiologist and the heart surgeon talk with the patient, looks at their other comorbidities, other medical conditions, how fit they are, how active they are, and figure out what would be the best therapy for that particular patient. This is how the TAVR procedure is done in a nutshell. So we basically go in through a transfemoral, which is groin or upper thigh approach, and the whole delivery system goes inside the old valve, and we oversize it. So basically, we just release the valve over there. The old valve get pushed to the side. The new valve gets deployed and instantly starts to work. And it's essentially a new gate, which opens completely as compared to the old valve, which was just opening very minimally. So multiple valve platforms, these are the two which have been used conventionally. Like most of the market share on the left, the shorter profile is the Edwards valve out of California. And these are obviously not directly from animal, but the left one, that's a derivative of a pericardium, like heart lining of a cow. And then obviously it's synthesized, processed a lot after that. The one. Yes, absolutely.
What's the fabric? What's the material made?
So the material actually, so the valve itself, you can see on top, I don't have a pointer, this one over here, that's basically the valve leaflet. This is made out of cow pericardium. So the lining of the cow is stripped and then it's processed multiple times and then also fused with other materials to make it a very durable material. They now call it the sapien brazilian. So this tissue, we played around with it on conference level, they bring it out. This is the main. Then around, obviously, we have this one is basically chromium and cobalt. That's the material around it. And then obviously the fabric as well. I'm watching they use like special fabric for that as well because see it. So the big thing obviously for the design, if you're asking, is this goes in. We want a nice seal over here so there's no leak around it. And then we have the tests which they test many replicated many times in the lab. They have it go through rigorous multiple life cycles of a patient to see the longevity of the valve. The other one over there is the Medtronic valve out of Minneapolis. That's a derivative of porcine like pig material, and that the framework for that is titanium. So the bulk of it, most of that time, I think they have around like 60-70% of the share market share. The valve is easier to deploy and it's a specific valve company. That is also a very good valve. Most of the time, their data is especially for people who have a smaller door frame, smaller annulus. So that valve usually works best for them. So,
Thank you.
No problem. Any other questions? Okay. So TAVR, obviously, me and another one of my colleagues over here, Dr. Selke, we do this procedure over here at Aurora BayCare. Dr. Selke has been doing it, I think, for about a year and a half. I joined him about 6-7 months ago. My background, I did training at Aurora St. Luke's. I did 3 years of cardiology there training. I did 1 year of interventional cardiology, which basically is heart stents, leg stents, stents in the carotid arteries. And then I did 1 extra year over there with them, during which time I deployed at least 400 of these valves. And then did, yes. And also the other therapies too, which we don't do over here, such as mitral valve clippings and tricuspid valve clipping and stuff, which I've trained for that as well, but we don't have those options there. Just for full disclosure, obviously not, I'd like to think, obviously, I mean, not because of the skill of the doctors over here, but if in rare cases we have patients who are high risk and we feel that just with the capacity of the hospital, they need to be in a quaternary care center. I can always just call other physicians at Aurora St. Luke's and make sure that patients get good care and continuity of care over there, and they can get those complicated patients over there as well. So, yeah, absolutely. Go ahead, ma'am.
Busy.
Yes.
So then, what kind of tests do you do? And you have to determine that's the reason versus something else.
Absolutely.
I just,
No, so these are the classic tests. And then everything, so I will explain them that basically everything in clinical context. So the first thing that we do is do an ultrasound of the heart. So these pictures over here, this one and this one is the ultrasound. And then this is normal moving towards severe. So the first thing that I would do is I would take a look at the heart picture on an ultrasound to see exactly what it looks like. Just looking at it, I would make sure that the valve is very, very tight and kind of calcified, and that is the main problem. Then I would check where this pressure is coming across the valve. Make sure that the calculation is okay and tweak around. That would be the first thing. The second thing that we do is the heart CT over there, the top right. That shows how much calcification in that tissue is. And then we also get a specific calcium score, which tells us whether the valve is severe or not. It has to be about 1,200 in females and about 2,000 to score. And so that's for us to. There are other ways too, like in some cases, still the question is not clear. So in those cases, we basically look at an invasive gradient, right? Taking the patient to the procedure lab, to the cath lab, and going directly through, obviously, either the porch lab, going through an artery over here, go across the valve and check the exact pressure across. So that tells us basically if the valve is a problem.
so that would kind of be
So an
not
echo,
your first option.
not the first option. In most patients, it's an ultrasound of the heart, which is an echo, and then a CAT scan. Those are the two things happening. And in most people, that usually defines the problem, and that shows us that clearly that's what's going
We do have one question on mind, if you don't mind.
on. Absolutely.
Can you speak to a replacement of an earlier cow valve replacement via open heart surgery? Is this more complicated than an initial replacement for a bicuspid valve?
It's a great question. So that's exactly, and I was going to talk about it as well. So surgical open heart surgery is a great treatment option, especially for people who are younger than 65, unless there is an extreme reason, very high surgical risk, extreme patient choice that, hey, I don't want open heart surgery at any cost. If somebody's younger than 65, which is mostly people with bicuspid valves, I would always talk to them and say, TAVR is not an option for you. I'm going to talk to my surgical colleagues. Open heart surgery is an option for you. So the reason for that is that, so two types of valves. The TAVR is a tissue valve. Most surgical valves are now being used as tissue valves. The second kind of valves, the heart valves, are mechanical metal valves. The discomfort for patients with the metal valves is that they have to be on a blood thinner on warfarin for the rest of their life. However, what we see as physicians and surgeons is what is the best treatment for the patient, which is going to last them the longest. Mechanical valves are more durable, meaning they can last decades. So for someone who has a congenital, a bicuspid, any such valve, they're much younger, 40s, 50s. By default, surgeons are going to put a mechanical valve so it can last them much longer. The data for, and the second now part of that is the tissue valves, which is the surgical valves and the TAVR valves. So these valves, the surgical valves have been there much longer, so we have more data on them. So we know for sure that this surgical valve is roughly going to last 10 years or 15 years and stuff, and roughly that timeline. With TAVR valves, we hope that they are as good as surgical valves, but obviously we have to be humbled by what science we have and what data we have. So those valves conventionally we can say that at least they're going to be good for 7 years to 10 years. in most patients. There's no guarantee. Hence, the 65 or even somebody who's otherwise extremely healthy and 70 and 72, for every patient that we deploy this valve before making the decision, we do the ultrasound, we do the CAT scan, we talk to the patient, we look at the heart arteries, we see everything in whole context. Is the patient does the patient have any other comorbidities? They don't have any concerning disease such as cancer or any other like significant problems, which would make us suspect that the life expectancy is not going to be more than one year or anything like less than 1 year. So after discussing all that, we cardiologists and surgeons, we sit in a room, we do a committee meeting, and then we figure out what would be the best option for that patient. So I was going to talk about those in the next few slides. So I thought probably best time to talk about that too. So TAVR in itself, obviously, as compared to open heart surgery, minimally invasive. So we just go, the main access is through the upper thigh to the groin, which as soon as I take the delivery system out, I do 2 sutures over there and it gets sealed at the same time. After that, the patient has to be in bed lying flat for about 6 hours. The recovery faster than open heart surgery. Most patients go home the next day. So the only reason we keep them in the hospital is to make sure that they don't develop a heart block, since the TAVR valve is next to the heart electricity system, and then also making sure everything else is fine, they're walking around, things are okay. Faster recovery, most patients within 1 day, they go home, and less pain naturally because it's not open heart surgery, which can have healing of the wound for a few weeks afterwards. So this is what we were talking about. The TAVR initially was for people who were only high surgical risks. Now, over the course of the last decade, multiple research trials and now guidelines have shown that TAVR is acceptable for low-risk people as well. So basically, what that means is you have somebody who is 70, 75 plus, and they can get surgery versus they can get TAVR. Even if they're low risk to undergo surgery, doing either TAVR or surgery, it's the same when it comes to outcomes. At least 7 years data we have that they look the same in terms of stroke or death or heart attack. This we talked about. And then I think, ma'am, you were asking about maybe when people have fatigue. So now, 2 years ago, 2 trials were published. One was a US trial, and another one was out of Scotland, where they looked at intervening or doing a TAVR on people when the valve became severe on what we did on ultrasound and CAT scan versus when it became severe and people have symptoms. So basically now they're saying, because for surgical open heart, they've been doing for decades that they would replace the valve by surgery, even if patients did not have any symptoms. So now the same concept, because we know that, hey, people don't have right now shortness of breath, they don't have chest pain, they're not lightheaded or fatigued, but the valve clearly looks to be severe. There's no question about it. In those cases, if we talk to the patient, and some people say we want to get echoes and ultrasound every 3 to 6 months and follow up, which is reasonable, and see if symptoms develop. Others say, I want to go for an early TAVR strategy. I don't have symptoms, but there is a significant chance things are going to get worse. Right now, my chances of getting through a procedure, my complication chances are less because it's elective, I'm healthier. In those patients, actually doing an early TAVR, like within 4 weeks of diagnosis, that was actually better in terms of death, stroke, and later hospitalizations as compared to when you intervene on when people had symptoms. So this was a very landmark study at TCT 2 years ago. So in the US, obviously with our aggressive health system, which is good in many aspects, so we intervene on average for asymptomatic TAVR patients within 4 weeks. And in Europe, there was a lag time of 5 months. So compared to them versus us, there was a clear benefit in our patients when we intervened earlier. So this is now a discussion. And over here, obviously, Because every procedure can have risk as well. So this is where I talk to my patients about each and every outcome, and I say that both are reasonable outcomes. And then it's more of like the risk perception and the choice of that patient, how they want to proceed, and that's what we've been doing over here. Like I said, so doctors, so we do this is the humbling part for us. We do the same exact technique 100 times, and 1 times out of 100, we get a complication, which is a major complication. We work inside those big blood vessels, go from the femoral artery all the way to the heart. Over time, those arteries also have plaque. So anything potentially can dislodge, go to the brain. Does it happen 1% of the time? Yes. Some studies 1 to 2, 3% of the time. Can happen with open heart surgery, can happen with TAVR. Again, many times we do the same thing exact, and then it just in some people we get complications. So that's very important to talk to people about before. Need for pacemaker. So there's a 5 to 8% chance of requiring a permanent pacemaker after people get a TAVR valve, just because the valve is deployed right next to the natural electric circuit of the heart. Sorry, go ahead.
Do they ever do the TAVR?
So the delivery system is much bigger. So the radial artery is not possible. The multiple access we can try. The conventional is obviously through the femoral artery, which is the easiest and the best straight shot, lesser chances of complications. Sometimes you can do right here in the artery, in the subclavian, but more chances of complications. So most places don't do that. We over here, since our program is a year and a half young, half years young, so we are doing transfemoral. If potentially the second option, which we did quite a few over there at St. Luke's with the surgeons over there, is the carotid artery right here. So that's a direct access. But for that, obviously, I can't go in there with a needle. The surgeon has to cut the skin. You have to expose the artery. They have to go in. And once they give me the access, then we go in and deploy the valve, come out, and they basically suture the skin. And it's a very safe option under the hand of good surgeons. Better to the groin, but sometimes the groin arteries are not big enough, or they're very calcified and there's not enough room to go in there. So if that's the case, then the next step is over here. So what me and Dr. Selgi, we've been doing over here is that if somebody does not have a viable groin access, then we talk to the patient, and the ideal situation is to send them to St. Luke's in Milwaukee, where they can do carotid access.
Some people have so much trouble with some people.
Yes.
Don't feel. My husband had this done. It was through the groin. He's a good healer.
Yes.
So he was okay.
Yeah.
Yeah.
Absolutely. Yeah, and that exactly. So, and the groin side, in most cases, we are able to control it. So what we do is, as soon as we go through a needle and get the access, we basically deploy 2 stitches, 2 sutures. So we do them on the artery wall, and then we just leave them on the side. We do the whole procedure. After we take out the system, we pull on the sutures and they bring the artery together. So that's a very neat way to fix it, but it doesn't always go as planned, because sometimes those arteries are very thick, they're very calcified. So the suture, we can't see. Obviously we go by feel and we try to move around, and obviously we use an ultrasound, but still things are not 100%. So sometimes that suture can be on the calcium, it doesn't go into place. So then we have to kind of improvise and put some pressure. Discomfort for people where we have devices like a FemStop, which is just pressure over here. So sometimes people have to be in bed longer overnight, and we have to put that device over there. So there's a way to do it. Very, very, very rarely. I haven't been in a TAVR case like that. I've been in other cases where things happen. Very rarely. You can always go in and put a stent over there. If there's a rupture, anything to the artery, you can put a stent inside, and basically it closes that area, the hole, if you have a hole in there. And this is essentially the last slide. We talked about surgical mechanical valves. We already talked about. The concept for us now is lifetime management since these technologies are getting good. So what we look at is not just one procedure. Whenever we are planning for these towers, what we're thinking about is the lifetime management for that patient, meaning doing valve in valves. So we know that conventionally those mechanical surgical valves at a younger age, open heart surgery, they're going to last a long time. With surgical or TAVR tissue valves, on average, probably they'll last 8 to 10 years. Some people can be luckier, they can last longer. In some, they last less time as compared to that. So then we have to look at these CAT scan, the sizing, the nitty-gritty of it, also how we deploy the valve, how deep it is, so we can accommodate future valve. So let's say if I see someone who gets a valve at around 80, 85, I hope that the valve is deployed well and is going to last the lifetime for them. If somebody gets a valve at 70 to 75, then I would pay particular attention to how I'm deploying it a little bit deep, and then making sure that there's enough room over there in 10 years to potentially go and do the procedure again, put another valve. So you can actually go in and you can stack valves one inside the other. There have been valve in valves. There have also been valve in valves. And they can go either way. You can have surgical valves with TAVR valves and TAVR valves with surgical valves. So the concept being that obviously quality of life and living longer for a patient, keeping that in mind whenever we do the first valve. So that's like a very important concept, especially since the technology is getting better. And then we are doing these procedures in relatively younger patients and also people who basically are lower risk for surgical.
What is really, is the concern start to arise at what number?
So calcium score for the aortic valve. So it's one of the markers. So there's no definitive test which would confirm a diagnosis of aortic stenosis for me. The best way is to kind of get a clinical picture, an idea of the patient. And the most conventional and classic way is the echocardiogram, because it shows me dynamic pictures. The heart is beating. We take beating pictures of the heart real time, and we see the pressure gradient and we see the valve opening. So that gives me more information. The calcium score is an extra adjunct to it, where a calcium score, if I have a question that, hey, maybe this valve is severe or not, that sometimes could be a tiebreaker. For females, a calcium score of 1200 is, or for males, a calcium score of 2000. Those usually indicate that the aortic stenosis is severe. And this is obviously separate than the coronary artery calcium score. Most of the calcium score that people get done with their primary care physicians, that's usually the heart arteries, the coronary arteries. This is for the valve for the door. So that's a separate one. We always, obviously, clinical picture, because naturally we also have to justify and we have to like sleep with our decisions as well. So if in many people, some people, I can have a calcium score which is severe, but maybe those people don't need a valve. So I have to look at the first thing for me is, and obviously learning it from experts who've been doing these like 5,000 towers and more, the first thing is taking a look at the real-time dynamic pictures of the heart and seeing, and then that's usually like, is this a valve severe or not? In some cases, what happens is I get a patient referred for severe aortic stenosis. You look at it and the valve is opening nicely. I'm like, there is no way this is a severe aortic stenosis. There are other ways to test it. Then we obviously look at now, then the question becomes what's happening. So they can be mimic. People can have amyloidosis, which is thickening of the heart muscle because of infiltrative protein. They can have the problem under the valve or below the valve and not the valve. then you get imaging to differentiate that, so you can look at all that. So that's where we have to do our due diligence with the planning. Sorry, go ahead.
If you have to stack the valves, is the procedure more complex?
Absolutely. Absolutely has to be more planning for it. The valve and valve procedures, the sizing part of it, where exactly we put it, and then the leaflets of the old valve, how much we pin them on the side, how much overhang we have, those are concepts. And then another significant thing to think about is how far are the leaflets of the new valve, the doors, how far are they going to be from the coronary arteries, which are the heart arteries which supply blood to the heart. Because obviously the devastating thing can be if you don't do it in a proper way, and those doors can actually block the heart arteries, and that becomes a severe complication. So those are things to consider. And yes, that's usually a much more challenging procedure. And we are not doing them over here. There are other techniques, special techniques of leaflet modification, where you actually go in and you slit the leaflet of the previous valve, so there's enough room to put a new valve. And then, of course, in people who are viable surgical candidates, there's always with good surgeons, they can always take this valve out, explant this one, put another one. So multiple ways to do it. Everything is on a case-by-case basis based on the patient. I think that was the last of my slide. Any other questions open for? Perfect. I think the final thing that I'd like to say, obviously, it's these the summarizing the best medicine is preventive medicine. Like I always joke with people. So I am originally from Pakistan. My dad still practices over there. I go there once a year. Whenever I go there, just the way things are over there, I stop in Dubai and then I go there and then I come back. When I come back to the US, I go to a restaurant, I go around. You get a different sense, obviously, like different sense of diet and composition and lifestyle. That's a key. Then the other part is exercise and taking care of yourself. So if those things are done, in most cases, heart disease still is, a lot of it can be prevented. So all these procedures, we obviously are trained at them. We love to do them. They come at a cost as well. And there's clearly nothing as good as the native valve and our native body. But of course, if things happen, then we are here to take care of them. All right. Thank you. Yeah. Thank you.
Okay, we'll take a 5-minute break and then we will come back with Dr. Shaolin.
Do another question.
I mean, we can turn this up. It's just this though. But you can hear like a little bit through there because like when you tap the mic, which makes see like it kind of. I'm gonna say if you talk about yeah. All you have to do is hit this button or you don't have a clicker. So if you want to point to anything though, can I get my mouse and put it in? Because I have a no, I have a otherwise. I might have that. I tried that one. It does not work. I'm gonna see if my mouse is in. Do you maybe? Okay. Yeah. Just because I'm a walker. Probably. There's not. I mean, the majority of. It's like a few.
There, so we have to be clicking today. Mark. I think this one is, oh wait, here, let's unhook this.
Yeah, when you said like that, said that, right, sorry, said that, and you did that.
What's gonna happen later?
Okay, well, from where I was looking, it looked like a laptop, so I'm glad it's just a folder, because that would have hurt.
You can move this over here so I can see. What is? I like your way. This is the BayCare way. Love it. Great way. Let's try this first here. I'm gonna see if I get it. No, what's the
That's
other
the
one?
keyboard, that's the keyboard light went on.
There you go. Okay. How do you want this?
As much room as I can.
Okay.
I'm literally.
Well, then let's do this.
Seems weird.
Yeah.
Oops.
So I'm gonna take this, just go.
Yep. Do whatever you gotta do.
Like that. Remind me as I just make myself home.
Hey, whatever it is, if you want to make this easy for you and there we go. All right.
You too. And all that.
There you go.
Sweet. Thank
You
you.
should be able to, I don't know if you can just click it.
I'm just gonna go, oh, sorry.
I'm wondering if it needs to like stay. You should be able to, but like if you hold it like that, like it shouldn't even have to be like on something.
That's normally what I do is I just walk around this, like.
I think it has to be like on this though. Yeah. Oh, so as long as it like the mouse part stays on the presentation, you should be fine.
Okay,
No problem.
cool.
But if something happens.
We'll just make it
Figure it
work.
out.
It's toy time.
Okay.
All good. Got me a full.
I'll let you do so. So if you go keep the alphabet. We don't feel like 2 hours. I feel like it was all good though. And like at 11, like. Whatever. And we're waiting for all 11. Hopefully. So nice out this weekend. This weekend, it's supposed to be. It's not that big. You know, this weekend, I'm like open the farm, but it was.
And work for it. Like Uber. Also, like just teach.
Yeah, we were on a walk last night and it was this couple walking like this little golden retriever puppy, like in an actual bed, like 4 months. Like, so like some pretty white fluffy fur, just lays right on. I'm like, good luck. And that is why they were like middle aged, but I'm just like, oh, right in the middle.
Yeah, we have a pond, so he lives in it in the summer. And it's just like, it breaks.
But they have so much fun. It's like,
That's all they have fun. Yeah.
Well, there's. Wait, one for that. What you doing?
I'm like, guys.
Well, that's what I'm going to. Yeah. But you know, just right. Yeah, the one for yelling, so it's in small like that. Senior crying, she's like, marketing vacation, so she puts together like black things and posts, but I. So the one that was just.
Yeah, so she covers gynecological oncology, general and vascular surgery, and plastic surgery, and skincare from gaps, which we're like. And skincare. So.
We will get rolling. We have Dr. Kimberly Sholland with BayCare Clinic Eye Specialist ready to present next, and she will be touching on dry eye. So enjoy. Super exciting.
Well, thank you for having me. I probably won't be talking into the microphone if that's okay. So if you can't hear me, just let me know, but I have a big voice, so we should be good there. Like Allison said, I'm Kim Sholland, and I have the utmost pleasure of treating dry eye. And so I started at BayCare at the end of 2022. And because I have really supportive bosses and because I have a really good team behind me, they granted me my wish in starting the dry eye clinic within BayCare. I personally have a very deep passion. I hope you'll be able to see and hear that today for treating dry eye. Dry eye is one of the most underdiagnosed and kind of shoved under the rug kind of conditions when it comes to the eyes. And I found that deep passion, not only in the interesting and how interesting dryness is, but also I have a very deep responsibility in dry eye patients, making sure that they feel seen and that they feel heard. Because although it can be mild and it can be more irritating or a little nuanced, it can be absolutely debilitating. And so I really want to make sure that patients have an opportunity to feel seen, feel heard, and also get correct treatment and management of this condition. So we're going to start by taking a very bird's eye view of dry eye. And we're going to kind of go through a lot of different topics today, so we'll get right to it. Dry eye, what you're told, the general public of what dry eye is described as, are these pictures. Severe pain, severe dryness, sand in your eye, feeling like you're getting blasted with gravel, severe redness, and this deep burning. And although those are true, and especially in severe dry eye, they can be very true and very real for patients to experience, it's much more than that. In reality, the very first symptom, the classic hallmark symptom of dryness, is fluctuating vision. So what does that mean? It means when you're sitting down and you're reading your book in the morning, after 20 minutes, the words start to garble, or it feels a little hazy or a little blurry. And you blink a few times, or you take a rest, or of course, you give your eye a little rub, and the words come back to focus. It's when you're driving down the road and things seem off just out of nowhere. Give a couple blinks, move the eyes again, and you see clear again. That fluctuating vision is intermittent changes to a stable vision, whether that's blurry or whether that's a generalized disruption or distortion. That's fluctuating vision, and it is the utmost common symptom for dryness. In reality, it's also fatigue. So as we get older with the dryness, it's not being able to read that novel for 8 hours like we used to. It's not being able to sew. It's not being able to watch TV or do the activities you like because your eyes simply feel tired. In a world of technology, we also know that at the end of the day, when you're on the computer all day, we feel that fatigue. That fatigue is dryness. And then crusties in the morning. So if you're one of those patients where you wake up and within the hour of waking, you're grabbing that nice warm wash rag to clean off and wash out your eyes, you, my friend, have dryness. And so with that, we see, if we look to the bottom right, the dryness, the gravel, sand, dirt, redness, and burning, yeah, that's what we hear of dry eye, and it can be it. But to the left is more common, especially in the earlier stages of the disease, the symptoms of dryness. Fluctuating vision, we talked about, crusties, fatigue, and my personal favorite, itching. So when we hear of itching, we think allergies. And that can be true. But 9 times out of 10, when a patient comes into my exam lane or into our chairs, itching is actually dryness. Unless they're coming in with those really red, watery, swollen eyes with the severe sinus congestion that we have when we have an allergy attack, intermittent itching is hallmark of dry eye. Light sensitivity, and of course, as counterintuitive as it is, watering eyes is more often than not, dry eye. I think it's also important to understand what we as providers see or what we think of when we see dry eye. And so this is one of the charts that when I look at and see dry eye, this is what I think of. Now, I would never bore you with all the details of this, okay? This is a very extensive chart, but I hope your knee-jerk reaction when you see this picture is, whoa, or that looks complex, or there seems to be a lot of moving parts, or there's a lot of arrows and a lot of different pathways that this condition can go. And that's what I want you to take away from it, is that when I look at the eye and I look at your symptoms of dryness, it's actually quite a complex condition. And there are a lot of moving parts. And with that becomes a lot of different treatments and different ways that we have to manage it. Because of those three things, or just the very start of this conversation, we know that with the complexity of dry eye nowadays, it's much more than artificial tears. So that used to be the hallmark, put some artificial tears on and then send the patient on the way. And yes, artificial tears have their place. I don't want to underscore them, but now we know that it's much more of a complex condition and it's a lot more than just artificial tears. We are blessed that we have some major studies that have come out that specifically only talk to dry eye. And that's the DEWS 1, the DEWS 2, and the DEWS 3. So these are huge studies that give us a lot of information, have really gone down to the deep work of understanding the condition and how we treat it. We also know now that dry eye has a very strong link to anxiety and depression. And I see this in my chair all the time. And we also know that millions of people are affected by dry eye. Of course, we have a full spectrum of severity. It can be very mild, but it also can be very severe and everywhere in between. And so we know now that dry eye is much more complex and it requires a lot more than artificial tears. So let's go right into the basic definition. And I'm going to read it word for word. Dry eye is a multifactorial chronic condition that requires a multi-step approach to manage and improve patient symptoms. 3 words I want to highlight. The first one being multifactorial. There is no one thing that has caused your dry eye symptoms. It's many things, and we'll get through that, or we'll touch base into that a little more detail in the few slides coming up. Number 2, the most important word in the entire definition, chronic. I cannot, as much as I'd love to, cure your dry eye. It's impossible. Just like diabetes, just like high blood pressure, those conditions aren't cured. We don't give a magic pill and make all those go away. The same thing is true for dry eye. So not to be a Debbie Downer in the sense that it's chronic, but to give you a more realistic expectation, no one treatment's going to make you go out the door and feel better. It's a chronic managed condition going forward. And then lastly, I hope that you recognize from that slide that I showed you of the complexity of dryness, not just one thing that's going to make you feel better. It's multi-step approach. So different treatments are targeting different parts of that chart within the dry eye. And so it takes multiple things to make you feel and see better. I personally feel that understanding conditions gives you power. You are the captain in your ship when it comes to your health. No one does that better than yourself. So for you to be able to really manage your conditions well, you have to understand them. And so I want to take a very bird's eye view and step back, and we're going to go through a little bit of the anatomy so that you really understand what's going on. So when we talk dry eye, we're really talking about the ocular surface. And ocular surface is every part of the eye that's exposed to air. That's simple. For it to be healthy and optimal, it requires 3 things. Good lids, good tear film, which is the fluid that's covering the eye, and the good healthy cornea. When we talk about the lids, these are the, your upper and lower eyelid. They're doing multiple things. The first one is the blink. And that blink actually secretes part of your tears, so your tear film. If we look at this picture on the top, and I'm going to come over here and show you, these little worm-like structures, those are the glands that are housed within the lid. And when you blink, they secrete part of the tear film. So the actual blink, as well as the lid itself, is contributing to a healthy ocular surface. The lids and the blink of the lids does a lot more than that, though, too. It protects you. Something's coming at your eye, or you have a lot of debris in the environment, you blink a few times and it protects the eye. But it also takes the current tear film, that nice fluid that's covering the eye, and it removes it. In our environment, we are constantly in contact with different debris and allergens and etc. And that mixes in with our tears. So we want to eliminate that so new and healthy tears can be replenished. The tears themselves, so moving our way in, this is just the blanket of lubrication on the cornea. It's actually made of 3 different layers. In the green layer is the mucin layer, the big blue chunk is the aqueous layer, and the yellow layer is the lipid. Now, of course, the names don't matter so much, but what I want you to think of when you think of the tears, it's not just one fluid. It's a mixture of 3 very important parts. And more so, it's a mixture of 3 different parts of the tears that are all secreted in different parts of the eye. And so you have ones that are secreted up under the lid from your lacrimal gland, the ones that are housed in the lid that we just talked about, the meibomian glands. And then there's little cells on the white part of the eye called the goblet cells that secrete your part of your tear film, the mucin layer. And then the cornea, which is my favorite. So if we look at the top picture, you can see that this is kind of like your eye flipped up. And the green part at the bottom there is your iris. The cornea is the clear structure that balloons over that. So think of it like the basketball, like a half of a basketball sits over that. That structure has to be clear and very structurally sound for you to see well and see stable, okay? It's actually made of 5 different layers. And when we talk about dry eye, we look at the top purple layer being the most important, which we call the epithelium. The structural integrity of that tissue is utmost important to keep the eye healthy, the surface healthy. There's a really deep correlation, though, with that tissue with the nerves. We all know what nerves are. What do nerves do? They send signals to the brain. That's all a nerve does. Systemic, very basic. A nerve sends a message to the brain about feedback of what's happening. That epithelium, that utmost layer, is deeply intertwined with the corneal nerves. And so those nerves cause a healthy cornea epithelium. The corneal epithelium helps the healthy nerves. And so it's really that combination and that relationship that allows a healthy cornea. Okay. So in summary, let's go back to our basic anatomy. We have the lid, the things that the lids house, but also the blink that the lids create to create a healthy ocular surface. The tears, we need enough tears. We need it to have good quantity and quality. So we have to have enough of those 3 layers, but we also have to have the correct mixture of those 3 layers to create optimal, healthy tears. And then lastly, the cornea, that utmost layer of the eye that is deeply intertwined and deeply committed to the corneal nerves. Any questions so far? Okay. Going on that whole knowledge is power thing. So now we understand the basic anatomy, what makes a really good, healthy ocular surface. Pathology is when things go wrong. So pathology is when we get from a healthy eye to now what we call dry eye. And so we're going to take just a few minutes and kind of look into what that looks like. Working our way out to in. Blepharitis is one of the common subtypes of dry eye, and that is inflammation of the lids and lashes. So this is your crusties in the morning. These are the patients who have those kind of red, irritated lid margins. It has inflammation associated with it, which is shown on the picture to the right. You can see where it just kind of has that pink red hue to it, not that nice clean skin look. Specifically, one of my favorite conditions to treat in the clinic is Demodex blepharitis. I would argue that this is one of the most undertreated, overlooked conditions when it comes to dry eye. Demodex blepharitis is inflammation of the lids and lashes, specifically from a little critter that's living in your eyelids and your eyelashes. Very interesting. It's this little guy here. So you got 2 cousins. You got the brevis, that's one family member, and folliculorum, this little blue guy. Now, before you get creepy and crawly about that, what I always tell my patients is the Demodex mite's normally on you throughout your life, multiple times. He kind of comes and goes. In fact, I don't mind that he's there. I don't need a family reunion party happening. Okay? And so that's when it really turns from a normal to an abnormal. Patients become really symptomatic. We talked in the beginning of the symptoms with itching. That's him. So if you have a patient who's finding itching eyelids intermittently, I would guarantee 9 times out of 10, they have too many friends up in their eyelids. Okay, so the beautiful thing about this condition is it's very easily treated and we can really manage it to get it to a healthy level. What I always tell my patients is you can have 1 or 2 lone rangers of these fellows crawling around, but they can't bring everybody and their brother to make a nice house and housing unit, okay? One last thing on Demodex. If you're a patient and you feel like you've really hit a dead end where you've tried lots of different treatments and management options for your dry eye and you just feel like nothing's working, highly consider Demodex because he likes to hang out with bacteria and he likes to cause a lot of inflammation. And so if he's not under control, even if he's deep in that gland, kind of deep in that cavity, it can really impede and kind of prevent the other dry eye treatments from really working. Meibomian gland dysfunction, MGD. You'll hear this a lot of the buzzwords when it comes to dryness. Meibomian gland dysfunction is those little worm-like structures that we talked about. They're glands. When you blink, they're supposed to secrete. Now, in a healthy eye, they secrete olive oil. And as you can imagine, if you take a handful of olive oil and you move it across the surface, it's quite smooth, and it spreads very nicely. Meibomian gland dysfunction is when those glands change from inflammation, age, et cetera, and instead of that nice olive oil, they now produce peanut butter. And so if you can imagine taking a cup of peanut butter and a cup of olive oil and spreading them across the surface, we're going to have a different picture, right? And so you can see in the left one, that's healthy. And as we go on, the gland secretion just become peanut butter. Okay. When we're talking about the tears, what can happen with the tears? Well, they become unstable. And so when you blink, in between that blink, we want the tears to have a nice, smooth, waterfall-like feeling over the cornea. If they're not correct mixture and the correct quantity, they can actually break down and leave dry spot on the cornea. And so if we look at the picture on the left, the A, that's a normal, healthy eye. So it's got that kind of green glow to it. If we look at the picture in the middle, the B picture, you can start to see these little black areas here and this kind of wispy appearance. That's lack of tears. So the tears are not creating that nice smooth waterfall. It's more like taking a boulder and throwing it in the middle of a waterfall and the water goes around. Okay. And then C, you can see that's severe and unstable where there's kind of void of tears. That picture on the left, the C picture, is very highly linked to severe peanut butter. Okay, from the meibomian gland dysfunction. Because as you imagine, if you try to spread peanut butter across there, it's not going to smooth like an olive oil will, leading to the unstable tear film. And then lastly, the cornea epithelium. So the cornea with the epithelium, we want it to be smooth. Smooth is key for ocular surface and good clear vision and stable vision. If you look at the picture on the left, you can see where the top part has that kind of green glow or that just generalized green glow. If the epithelium, though, breaks down, and I'm not talking like a scratch, if you scratch your eye, I'm talking dry eye breaking down of that epithelium, we get what we call staining. And that, if you look at these pictures, it's that green kind of galaxy look right at the bottom here, okay? That is the epithelium breaking down from dryness. The picture on the left is mild. So that's a mild dry eye, and that's what we see a lot. Contrast that to the picture on the right, it looks like the universe, right? Tons of galaxy, tons of glowing across that. That is more of our moderate to severe dryness. The cornea epithelium is very unhealthy in that patient. And so we need to work to get that more clear and stable. That patient's having a really difficult time seeing. And so in summary of the pathology, we have blepharitis, specifically our good friend, the Demodex mite. We have meibomian gland dysfunction, olive oil versus peanut butter. We have unstable tear film, where we're just not having that smooth waterfall. And then we have the corneal staining, where the corneal epithelium is becoming diseased and breaking down. So now we've taken a bird's eye view. We have symptoms, we have anatomy, we have pathology. What causes it to go wrong? That's the next big thing. And so the first group is age and environment. The second one is eye-related causes. And 3 is systemic diseases. So just kind of breaking it down into the groups of what can cause things to go wrong. Here are some basic causes, and we'll go into some of these in a little bit more detail. Let's go into age and environment. So we love age. In my clinic, we always say we love birthdays. Better than the alternative. Birthdays bring us wisdom. And so we're all for birthdays. We're pro birthdays in our clinic. But as we all know, with birthdays, things start to work a little less optimally than when we were younger. And so those structures, those anatomical structures, they just can't keep up. They start to become relaxed. They start to not function as often as we like. And so just age-related dryness can be a strong cause of dryness. Environment. We have the blessing of living in a 4-season state, which I love. But with that comes changes in humidity. And so especially in the winter when we have all that forced heat air going through, our environment can cause dryness, and it can also cause fluctuations in our dryness. Smoker, I think this one's pretty easy. Everyone's been around a bonfire before. If you have the bonfire smoke go in your eye, it's going to dry you out. You feel burning, watering eyes. Imagine smoking every day. Of course, that's going to worsen and increase the dryness. And then screen time, the epidemic of screen time. Unfortunately, none of us can get rid of it as much as I'd love to. But when we are in front of a screen, we don't blink like we should. And as we learn now that we understand our anatomy, the blink is everything. A good proper blink to secrete those tears, replenish the tears, and drain the tears. If you're staring in front of any screen, doesn't pick one type of screen, you blink less often. So you don't secrete as much, you don't replenish things. And if you don't do that as often, those structures start to deteriorate. We'll go into eye related. Any eye surgery, that's a big one, huge one that causes dry eye, okay? LASIK, previous LASIK, glaucoma, retinal injections, and contact lens wear. I want to highlight though some of these. The first one being cataract surgery. I want to stand up here and make sure that I'm absolutely clear. Cataracts do not cause dryness. It is more the surgery itself. And of course, I'm not saying you shouldn't get cataract surgery. Cataract surgery is a beautiful thing. It can make you see wonderful. It can cure a lot of your symptoms that you're having. But it's also important to understand that what can happen as a side effect of the surgery. In any disease, in any condition, we don't often start off symptomatic. We often see signs and symptoms, or more so signs in the clinic before the patient actually becomes symptomatic. So in dry eye, that's no exception. In fact, we often see, especially in women, early signs of dry eyes in their early 20s and 30s. And it builds decades and decades and decades, the patient being asymptomatic. Unfortunately, cataract surgery is one of those where it can take a patient from being asymptomatic and flip them over to being symptomatic. And so I hear often in my clinic, everything was fine until I had cataract surgery. I never had dry eye, the cataract surgeon gave me dry eye. That's not entirely true. The surgeon didn't give you dry eye. The cataract surgeon didn't give you dry eye. It just switched you from being asymptomatic to being symptomatic. So it's important to understand that. And then any surgery, including cataract surgery, if you already have dry eye, expect a little bit worsen. Because of that surgical process and what they're doing to the eye when they're doing that surgery, a few weeks to a few months after cataract surgery, it can mildly worsen your dry eye symptoms. LASIK is another big one. Now that we know our anatomy, we understand that the epithelium and the corneal nerves are very tightly linked. They're very codependent on each other. When we do LASIK surgery, or when the surgeons do LASIK surgery, they actually cut the corneal nerves. Well, now we know that the corneal nerves are very important in making sure that the epithelium stays healthy. And so if you cut that, the nerves over time, them not functioning as well as they should, is going to cause a secondary dryness. And so the picture on the top, the red line is kind of like where you cut, and it cuts the corneal nerves. But I really want to highlight this picture. The red arrow is showing the LASIK cut. So when they do LASIK surgery, they actually make an entire circle around the cornea. Okay, so that's where they cut across to give you good vision with LASIK. And you can see our galaxy, which is our punctate staining, the decreased or not properly functioning epithelium is really sticking within that realm of where they cut. Glaucoma. Glaucoma, again, glaucoma itself does not cause dryness, but what they do to treat glaucoma is toxic. So I want to make sure it's clear, we can't not treat glaucoma, you'll go blind. Okay, glaucoma is one of those conditions where you have to treat it, otherwise vision loss can be devastating. The glaucoma drops, all the different colored caps, you'll hear people talking about their blue, yellow, purple cap. That's glaucoma drops. They're toxic to the cornea. I'm not saying toxic in the sense of like a chemical burn, but what I'm saying is it's not as healthy to the cornea epithelium as we'd like. And so over time, it induces dryness. The longer we have patients using these drops, the more drops that they have. And unfortunately, if they're a patient that has to have glaucoma surgery, that increases the risk of dryness. And then, of course, injections. You hear of these patients who get the shot in their eye, right? Whether it's diabetes or from macular degeneration, the process of that repeated injection will lead to a secondary dryness. Moving on to systemic diseases. We'll talk real quick about like cancer. I don't have ones to highlight that. We all know cancer can be devastating for the entire body, right? And more so chemo. Chemo saves lives, it prolongs life. It's a beautiful medication, but we all know in the generalized public that chemo takes a wear and tear on the body. And so that can lead to secondary dryness. Hormones, lack of hormone supplements, everything hormones is a very complex condition, but especially in women, understand that as we have changes in our hormones, dryness can come along with that. Shingles and herpes, that's a big one. What that does is it affects your nerve, which branches into the corneal epithelium or the corneal nerves. Now that we understand how important those nerves are, anything that's affecting that major hub can cause dryness. And then medications. We all have looked at the side effects of medications. There's a laundry list, right? All medications, whether you've previously been on them or currently are on them, can cause dryness. I want to highlight though diabetes. I think it's safe to understand that we all understand that diabetes can cause peripheral neuropathy, meaning you've heard of the patient who's lost a limb from being diabetic, correct? That happens because the nerves stop functioning. Well, diabetes is a systemic condition. And so what do we have in the eye that's super important for the dryness? The corneal nerves. And so if it's affecting nerves on the feet or the arms or the hands or wherever we're losing limbs from diabetes, it can also affect the corneal nerves and lead to a secondary dryness. Sleep apnea. Sleep apnea is also an epidemic in the US at this point. Sleep apnea is when we're just not breathing, getting enough oxygen when we're sleeping. Untreated sleep apnea causes dry eye because it causes changes in the lids, makes them floppy and kind of rubbery. And so they don't move, they don't blink as well as they should. But also treated sleep apnea causes dryness because you're wearing the Darth Vader CPAP, right? Well, unless you super glue that CPAP to your face, at some point it's going to leak air. And that airflow directly into the eye, night after night, day after day, month after month, is going to cause secondary dryness. And then autoimmune conditions. Rheumatoid arthritis, Sjogren's, graft-versus-host, sarcoidosis, all of the autoimmune conditions, they all come with inflammation. And inflammation is directly linked to dryness. So in summary, we have three main groups. We have age and environment. Again, we love birthdays. Birthdays are a beautiful thing, but they do come with their responsibilities. Eye-related causes, and again, the systemic diseases. So now the most exciting part is what can we do about it? So now we understand the anatomy, the pathology, the causes. What can we do to manage dryness? When we talk dry, we like to really mimic the dental model. Dentist, everybody knows what to do with a dentist. You go in, you get your deep cleaning once or twice a year, and then you come home, and what do you do every day? If you're perfect, you brush your teeth twice a day, and you floss your teeth twice a day. That is the generalized, everybody knows that about teeth, right? Well, with the dry eye, it's very similar. You have your at-home treatments and your in-office treatments, and both are very important. So your basics, these are just some pictures of my favorite products. Basics are your at-home treatments. That's your ointments. They put in at night. Really thick, goopy Vaseline. Really lubricate the eye. It's your artificial tears. Avizia up there. I'll boldly say that's my favorite brand. Your lid scrubs, cleaning off all that debris, your crusties in the morning. And then, of course, the heat, the hot compress. Doing that daily for 10 to 15 minutes. What do we do in office? One of my favorite treatments are the amniotic. So amniotic, what are they? Part of the afterbirth. So healthy pregnancy, C-section. We work with a very specific group only called biotissue. It's part of the afterbirth. So the placenta, they scrub down one of those layers of the amniotic membrane. They scrub that down and place it on the eye. We work with a very specific group because I know that the membranes are ethically sourced and they're safe. And that is very important. There's a very dark market when it comes to membranes, so we take that very important as an important thing to source them correctly. But the best way to think of an amniotic membrane is it's like fertilizer. So if we look at the picture, you can see on the left-hand side, it looks like the plant's dying, withered away. And the amniotic membrane goes in there and fertilizes the soil so that then the plant can grow and you can have a nice flower. Same thing with the dry eye or the corneal disease. When we put the amniotic on the amniotic membrane on the eye, it absorbs very specific proteins and complex molecules that help just form a perfect little baby. And so that can really help reset and give the eye nice nutrients and fertilizer to help your dry eye symptoms. New lids is another in-office procedure. And I'll say quickly, a lot of these ones that I'm going to talk through are usually performed once or twice a year. Again, the dental model. Okay, so maintenance, proper care going forward. The new lids is an in-office procedure that's really helpful for those little critters. And what it does is it's an oscillating like toothbrush contraption, and that we scrub the eyelid. Sounds a little aggressive. It's actually very therapeutic and it's very nice. Patients usually feel they see clearer and brighter after the procedure. We go in there and we do a deep scrub that you just can't do at home to really break up that inflammation and break up a lot of that buildup on the surface that's causing the dryness. The NGRX. This is an in-office procedure again that's working on the peanut butter. Okay. You can see I'm doing it to the patient in the chair, but essentially this machine uses heat in a safe way to melt down the toothpaste so that I can then go in and quite literally squeeze it out. Okay, it doesn't hurt, you're numb, it's nothing invasive. But if we do that repeatedly once or twice a year, then it can over time get us more back to the olive oil consistency. Now, we're never going to get back to that perfect olive oil consistency, but to get you closer to that can really improve your symptoms and your vision. Lacquer fill. So we have the drainage pipe out of the eye that drains your tears. Lacquer fill is a gel that we place in that drainage pipe to keep more tears against the surface. We know that tears now are dependent, or healthy tears are quantity and quality. And so this is really addressing the quantity. So if we just aren't making enough tears, if we can clog the pipe, then we keep more tears against the surface and the patient can feel a lot better and have a healthier eye. Vital tears is one of my favorites as well. That is actually your blood. And so what happens is they draw your blood out of your arteries and they spin it. So blood has different layers. One of those layers is the serum. So we call them serum tears. They take that and they send it down to a facility in which that makes your own artificial tear. Wildly fascinating and is wildly helpful. It's very therapeutic, kind of like the amniotic membrane, where it's giving you a lot of those protein, a lot of those very specific complex molecules for the surface of the eye, and it can be very helpful in restoring a lot of the damage from the cornea or in the cornea, and also really great symptom relief for dryness. The zest treatment, this is again is an in-office scrub. This one is addressing more inflammation. So this is a picture of my patient. You can see on the left-hand side, pretty red eyes. Inflammation, we always think. After the scrub, I saw that patient back about a month later, and you can see how much more white and pearly those are. Zest scrub is what caused that improvement for this patient. The zest is actually an okra-based treatment. And so okra is the common food that we eat, especially, in the South. But it has very therapeutic anti-inflammatory properties. And so we can scrub that against the eye and get a really nice deep cleanse in terms of inflammation, and it can be very beneficial for patients. And then Rinsata. Rinsata is another one that we offer in office. This is, I don't know how to describe it, it's going to sound a little aggressive, but like a gentle power washing. So it sounds very painful, but it's not. Up under the lids, that's what that's showing, is up under the lids, there's a lot of buildup. There's a lot of inflammation, a lot of just dirt and scum type of thing. If we go in there and we gently lavage that out and clean that out, that can be very helpful in reducing and improving ocular surface health going forward. And then, of course, I want to highlight on the pharmaceuticals. What goes into the pharmacy, what kind of drops, what kind of medications. There's a laundry list of them. They're always coming out with new ones. Those can be very helpful for patient early disease state. Okay, so really early. What I always say with these kind of drops and these kind of medications, think of patients like in their 30s who have intermittent dryness. Not to say that we don't use these in the later stages for sure. You'll classically hear Restasis is one of the more common ones. They now have drops that bind the corneal nerves, make you secrete more tears. They have the nasal spray, which is Purevea out. So there's a plethora of those that we can send into the insurance. Of course, as you and I both know, when we're talking insurance, we play the insurance game. How much is your insurance going to cover and how much is it going to cost? And so that is one of the biggest hiccups when we talk about any of these meds is simply your monthly be quite substantial. So we try to work with that, with your insurance with that. So again, success, what is it? Well, just like anything else, when it comes to your health, you are the captain of the ship. And so it's both at home and in office for you. And those collectively over time can not only really improve your vision, but it can create a stable and clear vision for you going forward. Patients always ask me, what else can I do? What can I do at home? What interventions can I do? And I love that question. That means you're committed to your health. So we'll go through a couple of these. The first one is properly manage your systemic diseases. If you have uncontrolled diabetes, if you're not treating your CPAP or your sleep apnea, that is directly relating and contributing to your dryness. And so you really have to take responsibility for that yourself. If you are a frail diabetic and you're not doing what you should do and you're feeling really dry, the first thing I'm going to tell you is go work on your diabetes. Because we know that how important those nerves are. And if your diabetes is not controlled, it is causing your dry eye to be worse. One that's really simple and really effective is no vents in the face, in the car. So right now with the heat, of course, in the dead of winter, you put that fan on your face. And what does it do? It dries you out. And so when my rule to all my dry eye patients in the summer and in the winter, only on the feet and as little as you can on the windshield. That less forced air, in especially the heated air, can be very helpful. Another really underutilized one is the small humidifier by your bed. So as we age, we get those beloved birthdays. Your eyes often flutter when you're sleeping. They don't have that nice tight seal anymore. And so that can dry you out. And so if you put one of those little bedside humidifiers, like when kids are sick type of deal, if you put that by your eye and have that create a humid environment, you'd be amazed at how much a simple thing like that can really help. Of course, drinking more water is going to help. If you're more hydrated, your eyes are going to be more hydrated. Eye protection outside. You're outside and your eyes are watering. Pair of sunglasses. Put on a pair of safety glasses. It's protecting your eye. Breaks from screens, they're not going anywhere, unfortunately, but we can take breaks from them. Give us some good blinks in between, really work on the glands outside of the screens, and just stay ahead of that curve. And then the big one, which no one likes to hear, is no fans while sleeping. We know that those people who have to sleep with a fan on, it's usually for the white noise or just the air movement. So if you're one of those people, take your fan and put it towards the wall, away from you, or at least at your feet. Fan above you is the key to creating a nice dry eye environment. So in conclusion, I'd like to just have a little quote up here. The best time to plant a tree was 20 years ago, and the second best time is now. I want to reiterate, you are the captain of the ship of your health. It starts with you. You have that ability to be more preventative, be more advocate for yourself. You don't have to live with dry eye. You can manage it. We can make you feel better, but it starts with you. It starts with you having a conversation, asking questions. You're already here learning about things, which is great. But really, if we take ownership and responsibility, we can really have good, clear vision going forward. So with that, I just want to say thank you for hanging out with me. Thank you for learning about dry eye and any questions. Yeah.
Talk about small humidifier. I've always wondered, is there a big difference between a small humidifier and BayCare?
I would go humidifier. The literature always talks about humidifiers. Yep. Other questions? Yeah.
We use a humidifier daily from fall till summer, and it really helps. But I'm wondering if is dry eye, does it ever get better, or it needs to be managed the rest of your?
Mostly the rest of your life. Yeah. So what I always tell patients when we talk about, kind of the the prognosis of it. You can have seasons of really mild symptoms where we have everything perfectly aligned. You're doing very minimal at home. There's a lot of contributing factors to that, but then you're always going to have hiccups. And I always use the analogy or the comparison to a bad back. So once you tweak your back and you have a really bad back injury, that kind of walks with you forever. You know, you can go years and you feel fine. You just do a little basic movement, keep everything nice and limber, and then all of a sudden something tweaks it. It always happens. I can speak that for myself. But we don't ever just, and then at that point, you know, when you have that tweak back, you go back and you do your exercises, your physical therapy, and then you're good for a while. And the same thing goes with dry eye. So I can't cure it, but we can manage it at varying degrees going forward.
How much is it connected to glaucoma before, or, I mean,
Strong.
one or the other?
Yeah, strong, very strong correlation. Glaucoma is a generator for dry eye. And again, I want to make sure that I'm very clear. We have to treat the glaucoma. It's very important. You will go blind if you don't treat the glaucoma. So it is most important, and your docs who are treating your glaucoma are doing the best thing for you because they're preventing blindness. But with that, just like any other medication, any other treatment, you always have side effects. And one of the side effects of glaucoma treatment and management is dryness. So it's very strongly linked. The question is, yeah.
So I'm on a generic version of this.
Yes.
Is that something that I'll just be on for the rest of my life?
Typically, I have patients who, if they're using other treatments, can get off of it. But then again, that season might be a year and then we might have to get back on it. So it's not uncommon for patients to kind of like get on and off treatments as long as we're doing something about it. Totally. Yeah. I wouldn't like self-dose those kind of medications where you're like, oh, I'll use it once a week. I wouldn't necessarily do that. But if we communicate and we're like, hey, you're feeling really good. This thing is costing you $150 a month. Let's try to go a season without it, and I'll see you back in 4 or 6 months. That's how we kind of approach those medications. Yeah.
Mention about LASIK contributing.
Correct.
Are there any new, better ways of doing eye correction surgery without
Reducing the dryness? Not in terms of like a LASIK field or a LASIK like area. We've already made improvements. They used to do the RK, which was a corrective surgery. That was worse than LASIK. And so we've now walked away from that, which is good. Now if we hit a certain age range where cataract discussion comes into play, I would recommend cataract surgery over the LASIK surgery, because cataract surgery is also a corrective type procedure or surgery. But in terms of LASIK specifically, no.
Yeah. What is your stance on brightening eye drops?
So I love Lumify over Visine. Lumify is the new and improved Visine. I would say use them sparingly. So I would call them my bride drops. So if you're gonna go and you're gonna walk down the aisle on your bride, your wedding day, for sure. Certain events, certain social events, or if you're going to a photo shoot, for sure. But on a day you feel like you need to grab those every single day to bring redness down, you should probably be evaluated for Demodex blepharitis, because it usually causes that red, especially in younger patients, that red kind of lingering eye. You probably want to be evaluated for that. But yes, definitely Lumify over, and only twice a day. So. Any other questions? Thank you. Thank you.